injury caused by the impact of a blunt object against the body, resulting in damage to underlying structures. Common causes include motor vehicle collisions and falls from height. Clinical features and diagnostic studies vary based on the type and location of blunt trauma. Assessment of patients with blunt trauma follows the systematic evaluation outlined in the Advanced Trauma Life Support (ATLS) algorithm: primary survey, transfer to a trauma center, if indicated, secondary survey, and tertiary survey. Management involves treating immediately life-threatening injuries and surgical repair of traumatic injuries. See also Management of trauma patients and penetrating trauma. 7. Exo. Overview. Management of blunt trauma is based on the type and location of the injury. Recommendations in this article are consistent with the 2018 guidelines on ATLS. 1. Types of blunt trauma /2-1. Sent open wounds, example abrasions, lacerations, contusions, sent fractures, sent crush injury, sent acceleration deceleration injury, example coup contra coup injury. Blunt trauma injuries by mechanism 2-1. The most common causes of blunt trauma injuries include motor vehicle collisions, vehicle pedestrian collisions, falls from height, and bicycling injuries. 3. Blunt trauma injuries by mechanism, LT, mechanism typical injuries. Head/neck, facial fractures, traumatic brain injury, TBI, C-spine injuries, thoracic, blunt thoracic trauma, abdominopelvic, blunt abdominal trauma, musculoskeletal, lower extremity injuries. Frontal impact. Rear impact *, head/neck, TBI, C-spine injuries, including whiplash injury, MOT Hickel Colisi MVC Tervenical Collins. Sent head/neck, TBI, C-spine injuries, side impact, sent thoracic, blunt thoracic trauma, sent abdominopelvic, blunt abdominal trauma, pelvic fractures. Rollover * complex injury patterns. Ejection from vehicle complex injury patterns. Windshield-related trauma, head/neck, TBI, skull fractures, C-spine injuries, facial fractures. Thoracic, blunt thoracic trauma, example sternal fractures, rib fractures, pulmonary contusions, seatbelt-related TEAEOS, abdominopelvic, blunt abdominal trauma, MVC-related trauma mechanisms. Head/neck, corneal abrasions, C-spine injuries, musculoskeletal, extremity fractures and/or injuries. Other, burns, airbag-related trauma. Low-speed collision, musculoskeletal, lower extremity fractures, example tibial fractures, fibula fractures, knee injuries. Head/neck, TBI, motor vehicle pedestrian collision, thoracic, blunt thoracic trauma, high-speed collision, abdominopelvic, blunt abdominal trauma, pelvic fractures, musculoskeletal, lower extremity injuries. Head/neck, TBI, facial fractures, thoracic, blunt thoracic trauma, motorcycle collisions. 4. Abdominopelvic, blunt abdominal trauma, musculoskeletal, vertebral fractures, lower extremity fractures. Head/neck, TBI, facial fractures, abdominopelvic, handlebar injuries, musculoskeletal, other fractures, example clavicle fractures, distal radius fractures, rib fractures, other, abrasions, example road rash. Bicycle collisions. 5. Head/neck, C-spine injuries, abdominopelvic, pelvic fractures, renal injuries, musculoskeletal, lower extremity fractures, example calcaneal fractures, vertical impact. Falls from a height. 6. Head/neck, facial fractures, thoracic, blunt thoracic trauma, horizontal impact, abdominopelvic, blunt abdominal trauma, musculoskeletal, upper extremity fractures. Back collapse. Find text outline. * thoracic, rib fractures ground level falls abdominopelvic, pelvic fractures sent musculoskeletal, extremity fractures. Battery * head/neck, TBI, facial injuries, example nasal fractures, zygomatic fractures, mandibular fractures, blunt neck trauma. Blunt trauma injuries by location, 1. Blunt trauma by body region Phi. Location potential injuries. Degree TBI fractures, skull fractures, facial fractures * wounds, facial wounds, scalp lacerations * traumatic eye injuries. Head. Tracheal injury * esophageal rupture neck * vascular injury, example carotid artery, vertebral artery, jugular vein, * cranial nerve injury, example vagus nerve, recurrent laryngeal nerve, * C-spine injury. Chest wall injury, example rib fractures, sternal fracture. Cardiovascular injuries copyright blunt cardiac injury, example cardiac contusion, commotio cordis, copyright pericardial effusion, cardiac tamponade copyright blunt thoracic aortic injury pulmonary injuries chest copyright blunt pulmonary injury, example pulmonary contusion, copyright hemothorax copyright pneumothorax, example tension pneumothorax, copyright tracheobronchial injury diaphragmatic injury esophageal rupture spinal cord injury. Diaphragmatic injury gastrointestinal perforation, example duodenal rupture, small bowel injuries, example duodenal hematoma, large bowel injuries SS pancreatic injuries splenic injuries, example splenic rupture, splenic laceration, liver injuries, example liver hematoma, liver laceration, genitourinary trauma, example renal injuries, bladder injuries, pelvic fracture. Abdomen and pelvis. Fracture dislocation neurovascular injury crush injury compartment syndrome. Extremities. L and blunt chest trauma. Approach to blunt chest trauma, 1. Ensure the following components are included as part of the standard management of trauma patients using the ATLS algorithm. Primary survey. Identify and treat respiratory failure and shock, tension pneumothorax, massive hemothorax, and cardiac tamponade. See management for details. Perform resuscitative thoracotomy in pulseless patients with previously documented signs of life. 1. Copyright C. Traumatic circulatory arrest for the management of cardiac arrest due to trauma. Send secondary survey. Examine the chest for paradoxical chest movement and crepitus. Copyright assess for indications for urgent thoracotomy. Clinical features. Hemorrhagic shock and / or obstructive shock, example hypotension, tachycardia, respiratory distress, example tachypnea, hypoxia, absent or decreased breath sounds jugular venous distension pain, example chest pain, rib pain, pleuritic chest pain, chest wall deformity, example flail chest, subcutaneous emphysema tracheal deviation. Back collapse fine text outline. Registered esophageal injuries may be missed initially. Suspect esophageal rupture in a patient with left-sided pneumothorax without apparent rib fracture. Diagnostics, 271 I8. See Urgent Diagnostics for Trauma Patients for a comprehensive approach to trauma imaging. Sent Bedside Assessment, CXR, EFAST, ECG Sent CT Imaging in Trauma chest CT with 4 contrast copyright CTA chest if vascular injury is suspected sent additional testing, bronchoscopy, esophagoscopy, echocardiography. Management, LL2. Pulseless patient, resuscitative thoracotomy sent close monitoring of vital signs sent definitive surgical management after stabilization. WA Urniotes. Lee chest wall injury. Rib fracture 112. Etiology. Sent blunt thoracic trauma, example MVC, fall from height, non-accidental trauma copyright. Sent pathological fractures. Clinical features. Sent pleuritic chest pain respiratory distress, example tachypnea, dyspnea, chest wall tenderness, bruising, and / or deformity. Sent crepitus plus flail chest copyright caused by 3 or more adjacent ribs fractured in 2 or more places. Copyright paradoxical chest movement, the floating rib segment moves inward during inspiration and outward during expiration. 1. Diagnostics 2-2-13-28. Plus minor trauma, CXR, AP and lateral view, 8-4I major trauma, chest CT. ANQN. Treatment 2I15. Sent isolated rib fractures, typically managed non-surgically. Copyright provide pain management, example acetaminophen, NSAIDs, lidocaine patches. O encourage deep breathing exercises, example incentive spirometry. Sent multiple rib fractures and / or flail chest. Copyright intubate and begin positive pressure ventilation, PPV, in patients with signs of acute respiratory distress, see airway management. 16-0 manage pneumothorax and / or hemothorax with chest tube placement. Copyright flail chest, consult thoracic surgery for surgical management. In patients with flail chest and respiratory distress, positive pressure ventilation improves gas exchange and may provide internal stabilization while patients await copyright surgery. Back collapse. Find text outline. Complications. Respiratory failure, pneumothorax, hemothorax, atelectasis, pneumonia, pulmonary contusion, intra-abdominal organ injury. Other chest wall injuries. Sent sternal fracture, sent clavicle fracture, sent vertebral fractures. OES. Lee cardiovascular injury. Blunt cardiac injury, BCI, 8I. 191I1. Cardiac injuries from blunt trauma most commonly occur after high-speed MVC and range from minor asymptomatic injury to myocardial rupture and death. 2. Possible injuries. Cardiac contusion, a cardiac injury secondary to blunt force thoracic trauma, which causes myocardial dysfunction with a wide range of clinical effects, including chest pain, hypotension, arrhythmias, elevated cardiac biomarkers, and cardiogenic shock. Atrial and ventricular wall injuries, septal and valvular injuries, acute coronary syndrome, myocardial infarction, pericardial effusion and cardiac tamponade, myocardial rupture. Clinical features. Asymptomatic chest ecchymosis, chest pain or tenderness, hypotension, tachypnea, shortness of breath, tachycardia, arrhythmias, new cardiac murmur, muffled heart sounds, jugular venous distension, dizziness, syncope, cardiogenic shock, sudden cardiac arrest. 6. Consider BCI if tachycardia persists despite fluid resuscitation and hemorrhage has been ruled out. Diagnostics, 18LL19. See approach to blunt chest trauma for initial measures. ECG copyright obtain in all patients with suspected BCI. Copyright potential findings include equals arrhythmia, example sinus tachycardia, dysrhythmia, equals ST segment abnormalities, equals ECG changes in STEMI AV block, sent troponin. Copyright obtain in all patients with suspected BCI. O may be elevated in patients with coronary or myocardial injury plus echocardiography, 2 degree. Copyright obtain in patients with hemodynamic instability, abnormal ECG, or elevated troponin. Back collapse. Find text outline. Sent echocardiography, 2 degrees. Copyright obtain in patients with hemodynamic instability, abnormal ECG, or elevated troponin. OT may be performed if TTE is inconclusive. 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 Copyright potential findings include pericardial effusion equals cardiac tamponade equals myocardial rupture equals wall motion abnormality valvular injuries equals septal injuries. Sent additional diagnostics 20 copyright general imaging in trauma, example EFAST, CXR, chest CT with or without 4 contrast copyright CT angiography, for suspected vascular injury. Management. Initiate immediate hemodynamic support and continuous cardiac monitoring. Start treatment of underlying pathology, example management of cardiac tamponade, management of cardiogenic shock. Commotio cordis, 21I22. Definition, ventricular fibrillation and sudden cardiac death caused by a relatively mild non-penetrating blunt force trauma to the precordial area. Etiology, blow to the precordial area at a perpendicular angle, most commonly by a hard, spherical object, example baseball, golf ball, during a brief electrically vulnerable period of T-wave upstroke. Pathophysiology, blunt trauma leads to myocardial stretch activation of ion channels because of mechanoelectric coupling augmentation of repolarization and premature ventricular depolarization. Ventricular fibrillation 23 diagnosis is clinical and based on the following criteria: O. Blunt trauma to the chest followed by collapse. Copyright absence of structural myocardial injury, on imaging studies and/or autopsy, copyright ECG showing ventricular fibrillation, if obtained, management O. Immediate, cardiopulmonary resuscitation. Copyright long-term, cardiac workup, ECG, echocardiogram, cardiac MRI, stress testing, prevention. Copyright avoidance of sports that involve chest wall impact, example baseball, hockey, football. O. Use of chest protectors and/or safety balls may reduce risk. Blunt thoracic aortic injury 241-251 I26. Definition, an injury of the thoracic aorta resulting from blunt trauma, most commonly occurs distal to the left subclavian artery in the aortic isthmus. Etiology, rapid deceleration from blunt trauma, example MVC, fall from height. Clinical features, severity ranges from intimal lesions, example aortic pseudocoarctation, to thoracic aortic rupture. Copyright chest pain EO upper back pain O dyspnea, hoarseness, and/or stridor. Copyright dysphagia. Copyright chest wall instability and/or ecchymosis O new interscapular murmur. Copyright thoracic aortic rupture, signs of hemorrhagic shock, example tachycardia, hypotension, and tearing pain plus imaging. Copyright CXR, initial imaging, potential findings include, equals left main bronchus depression equals tracheal deviation equals apical pleural cap left pleural effusion, hemothorax, equals obscuration of the aortic knob equals mediastinal widening. Copyright definitive imaging equals CTA chest in hemodynamically stable patients equals transesophageal echocardiography. Management 26 copyright initiate blood pressure and heart rate control. Equals treatment, beta blockers, example esmolol, labetalol, and vasodilator therapy, example nitroprusside, nicardipine, if needed. Copyright definitive management equals endovascular repair, TAVR, equals open surgical repair plus prognosis, very poor, 80% of patients die before reaching the hospital, 2-1. Back collapse. Find text outline. ES pulmonary injury. Pulmonary contusion, IL-2-216. Definition, a lung injury from blunt trauma resulting in alveolar edema and hemorrhage. Clinical features. Copyright clinical features of respiratory distress, example dyspnea, tachypnea, cyanosis, eohypoxia. Copyright tachycardia. Copyright chest pain. Diagnostics degree CXR5. Equals patchy alveolar infiltrates whiteout hemithorax or diffuse opacity. Copyright chest CT, if CXR is inconclusive. Management. Copyright provide respiratory support, example oxygen, positive pressure ventilation. Copyright maintain euvolemia and avoid excessive IVF resuscitation. O monitor for respiratory insufficiency, example with repeated ABGs. Complications OERDS O pneumonia. Tracheobronchial injury L2. Scent definition, a tear in the tracheobronchial tree resulting from high-energy impact, decelerating forces, or a penetrating chest wall injury. Scent clinical features O dyspnea O sternal tenderness O subcutaneous emphysema. Copyright clinical features of pneumothorax O Hammond sign O hoarseness O hemoptysis. Scent diagnostics O CXR, subcutaneous emphysema, pneumomediastinum, pneumothorax. Copyright bronchoscopy, visualization of the lesion. Scent definitive treatment, surgical repair. Scent complications 2. O pneumothorax with persistent air leak. Copyright airway obstruction. Copyright bronchopleural fistula. Copyright mediastinitis. Ad. Suspect tension pneumothorax in patients with tracheobronchial injury and midline shift or distended neck veins. WA. OE. Blunt abdominopelvic trauma. Approach to blunt abdominal trauma 1F2. Ensure the following components are included as part of the standard management of trauma patients using the ATLS algorithm. Hemodynamically unstable patients. Copyright perform fast to quickly identify intra-abdominal bleeding. J. Back collapse. Find text outline. Hemodynamically unstable patients. Copyright perform fast to quickly identify intra-abdominal bleeding. 5. Copyright treat hemorrhagic shock with emergency transfusion and immediate hemodynamic support. Copyright identify obvious indications for exploratory laparotomy, example hypotension with a positive fast, peritoneal signs, subdiaphragmatic air on CXR. O associated pelvic fracture, coordinate interventions for pelvic hemorrhage control, example angioembolization, concurrently with emergency laparotomy. See initial management of pelvic fractures for details. Hemodynamically stable patients. Copyright obtain urgent diagnostics for trauma patients as indicated, example CT abdomen and pelvis with contrast. O identify other radiological indications for exploratory laparotomy, example significant hemoperitoneum or gastrointestinal perforation. O if there are no indications for surgery, initiate non-surgical management with serial examinations and close monitoring of vital signs. Copyright if there are obvious indications for immediate exploratory laparotomy, example hypotension and peritoneal signs, do not delay transfer to the OR for diagnostic studies. FL2. Clinical features 1. General features. Hemorrhagic shock, example hypotension, tachycardia, scent signs of peritonitis, example abdominal pain, abdominal distension, abdominal guarding, A. Scent decreased bowel sounds E. Abdominal bruising, example seat belt sign P. Ad. The absence of abdominal pain or tenderness does not exclude intra-abdominal injuries. 2. Specific injuries. Scent splenic injury O left-sided abdominal pain O referred pain in the left shoulder, care sign, liver injury copyright right-sided abdominal pain O referred pain in the right shoulder scent duodenal injury EO nausea and vomiting copyright bilious vomiting in case of gastrointestinal obstruction copyright epigastric pain scent retroperitoneal injury degree back and slash or flank pain or tenderness copyright periumbilical ecchymosis, colon sign, O flank ecchymosis, Gray Turner sign, MOE renal injury, hematuria. Scent diaphragmatic injury. Degree decreased breath sounds O bowel sounds in the thorax O respiratory distress. Extensive duodenal hematoma can obstruct gastroduodenal passage and manifest with bilious vomiting. Ad. Symptom onset in pancreatic injury may be delayed. Suspect herniation of abdominal organs into the chest if there are bowel sounds in the thorax after abdominal or thoracic trauma. Diagnostics, IL-8 Li 29. See Urgent Diagnostics for Trauma Patients for a comprehensive approach. Scent General Imaging in Trauma, CXR and Pelvic X-ray. Back collapse. Find text outline. SSE underscore Anna underscore ARSSSSSSSS equals SEIEI, SI underscore S, SISLSSSSSSSSSOOMNM sent general imaging in trauma, CXR and pelvic X-ray O performed for most patients after major trauma O may show free intra-abdominal air, evidence of diaphragmatic injury, and fractures sent bedside intra-abdominal hemorrhage assessment, FAST, EFAST, or diagnostic peritoneal lavage, DPL, copyright indicated for all hemodynamically unstable patients with blunt abdominal trauma. Copyright detects hemoperitoneum, collection of blood in the peritoneal cavity, sent CT imaging in trauma O minimum evaluation, CT abdomen and pelvis with 4 contrast. Copyright potential findings equals hemoperitoneum equals pneumoperitoneum equals splenic laceration equals liver hematoma equals duodenal hematoma equals pelvic fracture. O. Pancreatic, diaphragmatic, small bowel, and mesenteric injuries may be missed on initial CT imaging. 2. Management 21. Operative and Interventional Management 331. Exploratory laparotomy, example for hemodynamically unstable patients with a positive FAST and/or CT scan or signs of peritonitis. Angiographic embolization, example for patients with pelvic fracture, retroperitoneal hematoma, or liver injury. Injury-specific management. Plus splenic injury 1. Copyright monitoring for delayed splenic rupture. Copyright laparotomy and repair or splenectomy in unstable patients. Liver injury 2. EO non-operative management with observation and supportive care. Copyright or arteriography and hepatic embolization. O laparotomy and repair in unstable patients. Sent gastrointestinal perforation, laparotomy, C treatment of gastrointestinal perforation. Plus duodenal hematoma, bowel rest, nasogastric decompression, and total parenteral nutrition. 940-135. Sent pancreatic injury 36L28, O nasogastric suction and total parenteral nutrition. Copyright or surgical debridement, repair, and percutaneous drainage. OSOE. Blunt neck trauma. Approach to blunt neck trauma. 1. Ensure the following components are included as part of the standard management of trauma patients using the ATLS algorithm. E. Primary survey. O. Prepare for difficult airway management and secure the airway early. C. Treatment. Copyright immobilize the cervical spine with a cervical collar. Copyright consider neurogenic shock in hypotensive patients with no evidence of hemorrhagic or obstructive shock. Sent secondary survey. Degree perform neurovascular examination focusing on clinical and diagnostic features of BCVI. Copyright obtain urgent diagnostics for trauma patients, C. Diagnostics. E. Consult specialists based on injured anatomical structures, C. Surgical management. Back collapse. Find text outline. GFU. OE. Blunt neck trauma. Approach to blunt neck trauma. Ensure the following components are included as part of the standard management of trauma patients using the ATLS algorithm. Sent primary survey. Copyright prepare for difficult airway management and secure the airway early, C. Treatment. Copyright immobilize the cervical spine with a cervical collar. Copyright consider neurogenic shock in hypotensive patients with no evidence of hemorrhagic or obstructive shock. Sent secondary survey. E. Perform neurovascular examination focusing on clinical and diagnostic features of BCVI. Copyright obtain urgent diagnostics for trauma patients, C. Diagnostics. Copyright consult specialists based on injured anatomical structures, C. Surgical management. Associated injuries 2. Sent laryngotracheal contusions and lacerations. Sent fractures and / dislocations of the tracheal cartilages. Sent tracheal rupture, the partial or complete puncture or laceration of the trachea or the main bronchi. Sent blunt cerebrovascular injury. Clinical features, 1. Airway injury. Copyright signs of airway compromise, example dyspnea, O hoarseness and / or stridor. Copyright subcutaneous emphysema, example crepitus, copyright mediastinal emphysema, example Hammond sign, O hemoptysis. O dysphagia. Scent vascular injury. Copyright carotid bruit. O expanding neck hematoma. Copyright focal neurological deficit diagnostics. C. Urgent diagnostics for trauma patients for a comprehensive approach. Scent bedside assessment, CXR. Scent CT imaging in trauma. O vascular injury, CTA head and neck. O laryngeal injury, CT neck with 4 contrast. Treatment, L2. Airway management 4 degrees. If there are signs of airway compromise, call for help immediately, example emergent anesthesia and consult. Prepare for difficult airway management, example distorted anatomy, blood and / or edema, by an experienced provider. Cricothyroidotomy may be impossible if anatomical landmarks are invisible or deformed, example due to a laryngeal fracture. Emergency tracheostomy may be required. Copyright if intubation has failed. J. Surgical management. Scent vascular injuries, vascular surgery. Scent laryngotracheal injuries, otolaryngology. GOE. Tips and links. Sources. Last updated February 20, 2024. Back collapse. Fine text outline. Euro blunt trauma, 1/6. Pathomechanism of flail chest. Rib fractures. Separate chest wall segment. Expiration. Pathomechanism of flail chest v. Paradoxical movement of a separate chest wall segment that moves inward during inspiration and outward during expiration. Caused by detachment of a segment of the rib cage from the chest wall due to fracture of 3 or more adjacent ribs in at least 2 places. Copyright Boss. Blunt trauma, 2/6. Number 2 /